So today, for your very last day, your very last lecture day, it's actually not boring stuff, I don't think. I think it's kind of interesting, emergencies and disasters, because there is a chance that we may have something around here like this. Cameron, it's okay if you take your backpack off for a minute. Okay. You can stay a while. He is. He's preparing for an emergency. And you may get called on to at some point participate in an emergency drill, or you could travel somewhere and take care of people in an emergency or a disaster. So this is interesting. There have been things around here, like the bridge collapse at the Speedway. I don't know if y'all remember that. It was many, many years ago. There was when I was still at Rowan, which has been 15, 16 years ago, there was a fire in one of the dorms at Pfeiffer. And we had a massive amount of students coming in. I will never forget that you could still smell burning flesh up on the floors coming in the ED. That smell you never get over. So it's a horrible smell. So there are times when you may come in contact or have the opportunity to take care of people in an emergency or disaster. Now, there's a difference between those two words. An emergency is something that you're taking care of a group of people. It's unforeseen. It just, like the bridge collapse over the Speedway, an airplane crash. Like if we had an airplane crash at Charlotte Douglas, something like that, that would be an emergency, because it's an unforeseen act. Okay? You don't see it on the radar. You don't see it coming from wherever. It's an unforeseen combination of circumstances. A disaster is typically, you see it coming, like a hurricane. You know a hurricane is getting ready to happen, or a tornado, or something like that. The weather is looking suspicious. There are two different types of disasters. The first type of disaster is called multiple casualty, and it involves anywhere from 2 to 100 people. Multiple casualty disasters can be managed locally with local resources. The one hospital can take care of that number of people. Okay, so multiple casualty is a locally managed problem. Mass casualty means that it's more than 100 people. It's a very complex situation, and it usually involves state, regional, or national resources. So it's something that we can't handle on our own. An example of a mass casualty would be Katrina. I've got on here the Haiti earthquake. Now, some of you may not remember the Haiti earthquake, but that was a really bad situation. The tsunami, where was it? In the Philippines, those are mass casualty incidents. So they have to call in other resources to take care of the people, because it overwhelms the resources that they have in the hospital. So do you see the difference in the two? Okay. There, you can also further delineate disasters as internal versus external. At the hospital, you can have an internal disaster if it's a fire, like a fire at the hospital. It involves many, many people, but it's internal to the facility, versus external, which of course is outside the facility. Okay, so those terms are just some terms that you need to understand. Okay, so let's talk about mass casualty. Everybody should recognize this picture, right? This is one of those situations. Do you remember where you were? Oh. Yep. I had just got home from work.
I was in a class, in history class.
Jennifer was in 4th grade. Wow.
I was
They would? They wouldn't tell you what happened. That's what they said. 4th grade. So everybody's telling their stories. You know, in my parents' generation, it was, do you remember when Kennedy was assassinated? In our generation, it'll always be, do you remember what happened when the Trade Center, or the...
Jessica was in 2nd grade.
Jessica was in 2nd grade. Lovely. Wow. Do you know, and this is totally off the subject, but I just want to let you know that on February the 17th, I will turn 40. So I just want you to know that. I will be 40 years old. And I feel every bit of it this morning. Okay, so mass casualty means that again, the number of people have exceeded local resources. Okay, so remember, it's 100 plus people. The basic concept of triage, the basic concept of care in that situation is the greatest good for the greatest amount of people. Okay, now that means that there are times when you have to leave somebody, and that's one of the hardest things about dealing with a situation in a mass casualty incident. Okay. JCO, this is a couple of years ago, we were able to participate in this, and they've changed how they do it, but it was a lot of fun. In this class, the senior class, they would always call us from Rowan, and we would actually, you all would be the victims, because they have to conduct a drill twice a year. All hospitals conduct a drill twice a year on what to do in case of an emergency. And my senior students were always victims. So y'all would get flown in on a helicopter and come in on ambulances. It was so much fun. We had a lot of fun. But what happens is that JCO has set it up so that all hospitals in one region, so all the hospitals on the East Coast conduct the drill at the exact same time. And the purpose of that, what do you think would be a benefit of that? If everybody's doing it at the same time, to see what works. So if Rowan and Northeast and Charlotte hospitals and hospitals in South Carolina are all conducting their drill at the same time, then they can collaborate on how to share resources. So that if Rowan, for example, gets overwhelmed with casualties, they know where to send their patients. And they communicate with all those hospitals. So all those hospitals' communication systems are all linked together so that during the drill, you're communicating with hospitals in Georgia, for example. So it's kind of interesting that JCO requires all hospitals to do that twice a year. So twice a year you have to. And I think that this is true, and in a few years I may have to change this statement because people aren't going to remember it anymore. 9/11 changed everybody's perspective of being prepared. And I think that that's the case. I think that before then, everybody thought, oh, it's never going to happen on our soil, and it did. And then everybody thought, well, what are we going to do now? If terrorists can come on our soil, how are we going to be prepared? And so things totally changed with 9/11. Do you agree? Yeah. Okay, so let's talk about types of disasters. There are 2 types. The first type is natural disasters, and those are earthquakes and floods. This is a picture, you can't really tell, but this is one of the sites of the after effect of the tsunami. It's hard to tell in this picture, but that was like a town, and it's just all washed away at that point. Very, very scary. I can't imagine. And then there are man-made disasters, which include nuclear, chemical, biological attacks. So what would be an example of a man-made disaster? Chernobyl. The nuclear bombs in World War II. Nuclear meltdown in Japan. That's been fairly recent. Exactly. I still don't think that we have seen the last of all the results of that.
Yeah,
because of that tsunami. Yeah. So there's a lot of different things that we can create ourselves. Now, when we're talking about disasters, they level disasters nationally. Oops. I'm going forward. There we go. Disaster leveling. So a level one disaster means that we can deal with it locally again, similar to a multiple casualty incident. You can deal with it locally. EMS and first responders can respond to the situation. What do you think would be an example of a level one disaster?
Car wreck.
The bridge, a car wreck, a really bad car wreck involving multiple vehicles. A huge fire. The plant that burned in Spencer a few years ago, that would be a level one disaster. Okay, there were multiple people involved, but it was able to be handled locally. Okay? A level two disaster, again, requires aid from surrounding communities. So if it's a level two disaster, that means that you have to call in fire departments and EMS teams from surrounding counties, maybe even surrounding states. In the winter, really bad winters, the ice, and they have to go, or the oh gosh, what was it? My mind just went completely blank. Like if you've got a hurricane on the coast, and they bring in new power trucks, and you see them all going down the highway in mass, and EMS and Red Cross. Those are going to help the people in that area because there's too many situations for the local people to handle. A level three disaster overwhelms local and regional. And that's when you have to call in FEMA. You have Katrina as an example of a level three disaster. You call in FEMA, the U.S. Army Corps of Engineers. Federal assistance is released. Federal monies are released to be able to handle or take care of that situation. So Katrina, of course, is an example of a level three disaster. Okay? All right, so now let's talk about how are we prepared for a disaster or an emergency. I can go the right way, but be good. Okay, there are 4 phases of emergency response in a facility, in a hospital. There are 4 phases of emergency response in a hospital or in a facility, and this is what you need to know as a nurse. The first phase is preparedness. So every facility, even the ones, even like nursing homes or assisted living, have to have a plan to be prepared. A preparedness plan. It's a comprehensive disaster plan. There's usually a disaster planning committee. Does anybody know of that in their facility? You may not have seen it before, but every facility has to have a disaster planning committee. And there's usually a nurse representative on that committee. And what that committee does is they plan what's it going to take for us to be ready in the case of a disaster? Who's going to be in charge? Where's the response system going to be set up? Who's going to be in charge of going to the bank and releasing money? Who's going to be in charge of supplies? So you have a plan. You're prepared. Okay? And one thing that we're going to do today is you're going to make a plan for yourself. Okay? Because preparedness can happen individually as well with your family. Have y'all seen those? There's billboards up here and there about getting your family prepared, not waiting until the last minute. And that is the truth, because if you wait till the last minute, you're kind of up the creek at that point. So preparedness is a very important part. And when you're dealing with a big facility, for example, like Northeast, you can't wait till the last minute. You've got to know who's going to get the patients out. How are they going to go down? Are they going to go down the stairs? Are we going to put slides out the windows and let them go out the windows? What are we going to do? Okay? All right. The second is mitigation, the mitigation phase. And the mitigation phase of emergency response response is stockpiling supplies. You know that a hurricane is getting ready to hit. Okay? They have projected it. You know, the good thing about hurricanes, if there's a good thing, is that they can see it usually a couple of days out. Okay? So, you're stockpiling supplies. You're making sure that all the training has been done. You're making sure that communication systems are intact. So that I know that if I'm communicating with another facility and my phone lines go down, how am I going to get a hold of them? Am I going to have walkie-talkies? How am I going to get a hold of another facility? So the mitigation phase is you're actually actively getting yourself ready. You're getting yourself. It's a step past making the plan. The emergency response phase of a disaster is the disaster has occurred, now we're responding to it. That includes opening shelters, repairing infrastructure, so if there's damage to the facility, trying to get those prepared, and establishing critical care services. And again, nurses have to be ready with their own plans so that they can respond to the hospital when they call. And then the recovery phase of an emergency response is the disaster is over with. Everybody has been taken care of. Rebuilding occurs. And they also take this time to go back and say, okay, how did things work? Did everything work the way it was supposed to do? They go back and revisit the plan. So it's like the evaluation phase of the nursing process. Okay, I'm going back and evaluating what worked, what didn't work. Maybe we set up communication lines and they went down and we didn't have a backup. Or nobody planned on the fact that when we needed a release of funds from the bank, that the bank would be out of commission. Those kind of things. Okay? So you've got to think about what worked, what didn't work, and how are we going to handle it the next time a disaster occurs. Okay, so that's the recovery phase. All right. Hospitals always have an operation plan, and in that plan, just like we just talked about, their disaster plan, it includes these steps, okay? How to recognize that a disaster is coming and how to notify people. So how do you get the word out? So this is included in your hospital disaster preparedness plan. How do I get the word out that a disaster has occurred? Okay? Does it involve a phone tree? Does it involve emails? How? How am I getting the word out that a disaster has occurred or is getting ready to occur? Okay? Part of that plan is assessment of hospital capabilities. If you are in a small rural hospital, they probably, for example, Lexington. Anybody work at Lexington Memorial? They don't have a lot of the resources that they don't have a lot of the resources that a lot of bigger hospitals have. So in their disaster plan, they have to say, we can't handle this type of a patient. So if a patient, for example, with an acute cardiac problem comes in, they have to know, what am I going to do with that patient? Where am I going to send them? So you have to be able to assess your hospital's capabilities and know what to do with the patient in case they come to your facility. How am I going to get nurses called back to work? And that will happen. They will send out this mass email or this mass phone call, and they'll say, you've got to come in. Everybody's got to come in. And there's not going to be any of that. That's why I'm saying we've got to get yourself ready, because they don't care if you don't have child care. They don't care if you don't have power and your hair is all greasy because you haven't had a shower. They don't care about that. You've got to go. And so you've got to figure out, what am I going to do? That's why you've got to be prepared ahead of time. Where can I take my children so So I know that they're taken care of because I've been called out to work. So recalling personnel to work. Then they have to make sure who's going to be in charge of the command center, okay? The incident command center, and we're going to talk about that next. Who's going to be in charge of a command center, and where is it going to be in the hospital? When we were participating in Roanne's drill a couple years ago, they had their command center set up in a room off the emergency room. So that's where we all went for the after the disaster had occurred to talk about what had happened and all that stuff. That's where we went back, but that's where the command center was. Who's going to maintain records? And you can imagine that in emergency or disaster, keeping up with people is a very difficult thing, and making sure that you know where they're going and where they are and who came in and who was seen and who was treated. So who is in charge of maintaining the records? Public relations, because you know what's going to happen. The media is going to come down hard. You know, they're going to be right there at the hospital. They're going to be right there at the command center wanting information. Who's in charge of letting the media know what's going on with a disaster? And then who's in charge of equipment and resupply? One of the things that we're going to do on Monday in our disaster that y'all are going to participate in is we're going to choose one person to be in charge of equipment. I've got a big tub, and that's all the equipment that you have. And that person's job, I think that's probably the worst job, is they're going to have to decide whether or not your patient gets the last IV bag of fluids or not. So they're going to have to help decide. You're going to have to argue for your patient. Why does your patient need that IV fluid as opposed to the other patient? So we're going to be talking about that. You're going to experience that. Who gets the last IV needle? Can I reuse this needle? That kind of thing.
Okay.
Yeah. So equipment supply and resupply. What do you do when you run out of dressings? Okay, make your own.
Cut up some sheets.
Okay. So let's talk about the hospital command center. The hospital command center. Okay, and that's what I just mentioned, that you have some place in there that has a hospital command center. It's a specific structure with clear lines of authority. Okay. Right after 9/11, part of the plans that came out of that for the hospitals, they were standardized by Homeland Security and FEMA so that everybody's command center is the same no matter what facility you're in. So it doesn't matter. They let you pick who's the person who's the commander, but everybody has the same title of their role. So the hospital incident commander is chosen from the hospital. It's usually an emergency room physician, or a hospital administrator. It's usually an emergency room physician or a hospital administrator. It has to be somebody who has the authority to activate resources, okay, to call the bank, to release the money, or to activate personnel returning back to work, something like that. It is somebody who has the authority to activate resources. They have to have the ability to look at the global view of the situation, and facilitate movement through the system. Because if there's a clog in the wheel, everything goes haywire. Okay? So it has to be somebody. It can't be somebody who's a weakling. This person has to be somebody who has a strong background, management skills to get them through that situation. Then there is a medical command physician, somebody who is in charge of determining the number, the acuity, and the medical resources each victim needs. Okay, so that person is in charge of all the other physicians and the nurses. They're the ones who determine whether or not that patient deserves to get this treatment or not. Okay, that's a hard job. That's a very hard job. So they're the ones that determine the number, the acuity, and the medical resources that a victim needs. Okay? Then there's a triage officer. The triage officer usually is at the entrance of the emergency room. They're the ones who do a rapid assessment of that victim to know where to send them next. If it's something, and we're going to talk about this in a minute, they call the walking wounded. They can be taken care of in another situation. Maybe they have a broken arm, but other than that, they're fine. It's just a little simple fracture. They can go somewhere, whereas somebody with a punctured lung is going to be needed to be seen in an emergency room situation. So they send them to where they need to be. Okay, so the triage officer is somebody who does a rapid assessment and sends them to the location that they need to go. The ED charge nurse, the ER charge nurse, is someone who collaborates all the staff, all the nursing staff. So she's the one who says, okay, I need this number of people from this unit, I need this number of people from this unit, I need this number of people from this unit to take care of these patients. So they're the ones who collaborate all the nursing staff. They become in charge. Okay? Because if you have a nursing supervisor, that nursing supervisor is probably working with either the medical command physician or the hospital incident commander. So now somebody else has to be in charge of her duties, and that would be the ED charge nurse. And that's who says, I need this much help, or I need for you to call in this number of people. Okay? It's a very organized system. If it's not organized and if you don't have good communication skills, it can fall apart very quickly. Now, let's talk about triage for the triage officer. When you're triaging someone, you have to tag them, okay? So they come in, the triage officer is standing at the door, and they're the ones who say, okay, you go here, you go here, you go here. And then from that point, the medical officer is the one who says, okay, you have a punctured lung and you have a punctured lung, but yours is much worse because you have a cardiac situation on top of it. So they're the ones who take them from that point. So the triage person, and it may be more than one person, is tagging these people. And there are 3 color tags that you're going to have. And this is going to be on your test. What I'm going to do on your test is give you a disaster situation. And there are people in this situation. You're going to have to help me. You're going to have to tell me what tag they would get. Okay? So, the first tag is the red tag. This is emergency people. This is people who are in respiratory distress, okay, that are starting to turn blue. They're really having a difficult time breathing, okay? These are the people who are having acute chest pain. Acute chest pain. These are the people who are actively hemorrhaging. And these are the people with unstable vital signs. Okay? Emergent situation, we need to act now. Okay? They're in the middle of a heart attack. They're in the middle of an acute asthma attack, whatever. They have to be treated now. Okay? Then you've got urgent. Urgent is yellow. Urgent is yellow. So you've got red and yellow. It's less of a need than emergent, but it still needs to be treated. Urgent cases are severe abdominal pain. Multiple fractures. Or complex soft tissue injuries. Okay? These are the people who can make it another 30 minutes while you treat the chest pain victim, the emergent red tag person, but they still need to be treated quicker than the walking wounded. Does that make sense? Okay? They can survive. They're going to be in a lot of pain with those multiple fractures, but it's not going to kill them. Okay? The chest pain is a potential killer, right? Does that make sense? The walking wounded are the green tag. They are considered non-urgent. Okay? Non-urgent. That is your simple fracture. Now, when I'm talking about urgent people, they have either multiple fractures, they may even have a fracture that has gone through the skin. You know, you may see a displaced fracture that goes through the skin. That's still not considered emergent. That's urgent, and we need to take care of it. But emergent are, they're bleeding out everywhere. Okay? Non-urgent, they've got, maybe they're bumped up or scratched up or what. It may be that they have a broken wrist or a broken arm. What else can you think of that would be considered non-urgent? Skull lacerations. Something that maybe needs a, you slap a bandage on it and they'll be okay for a while.
Burn or something.
Maybe a small burn. Concussions, you have to be really careful with concussions because if they're confused and they have a obvious head injury, they may have internal. So I would consider a head injury an urgent situation until you determine. It may be that they're just so in shock. So you kind of have to determine, is it a head injury or is it shock? Okay, but non-urgent, you can see a lot of those needs coming in. That maybe they need a little stitch here and there. They have a sprained ankle or something like that. Those are the people who are considered walking wounded. And then the last tag, there are 4 tags. The last tag, and this is the hard tag. Okay, this is the hard tag, is the black tag. The black tag are either they're already dead, so that's not hard. You can figure that one out. Or those who are expected to die. And you look at those people and you know there's nothing you can do. Okay? They're trying to think of a situation where you would look at them. Maybe lost both of their legs and they're heavily bleeding out. I mean, you're going to know. You're going to know. You're going to look at them and they're going downhill fast and there's not anything you can do. Maybe it was a gunshot wound or something that they're going downhill. And those are the hardest. The people who are unconscious and they have life-threatening injuries. These are the people who you know are not going to make it. And those are the people who get a black tag.
I know reading the book in chapter 12, it talked about the black tag as far as like somebody with significant burns of full thickness. Yeah, they had a question on the following page and asked, you had to pick the person that was emergent. And they ended up choosing, the correct answer was the guy with 90% of third-degree burns. But would that be considered black tag instead of emergent? Because 90%?
90%, it depends on the type of burn.
Was third degree, full thickness. Just like they said on the things page, it was black tag.
Yeah, I would consider I'll give you a situation. Remember me talking about the fire at Catawba? Mm-hmm. It was, I think I said fire earlier, but it was Catawba. We had a kid who came in who died not long after he came in, and a teenager, and he was burned so bad he didn't feel pain. He didn't know he was burned. Those are the patients that you know are going to die because they obviously should be. I mean, he was talking about full thickness burns. I mean, it was all the way through, and he had swallowed fire. I mean, the fire had gone down, and he was burned on the inside as well. Those are the people you know. There was a situation not too long ago out in the news. I don't know if y'all saw that about the girl whose boyfriend made her drink lighter fluid. Did y'all see that? And then he lit her on fire. And they found her, and of course she died like 5 minutes after they found her. But those are the situations you know are not going to make it. Very rarely do burn patients. I don't know. I wouldn't give them a black tag.
That's just thing. So the test is probably by the that close to us to
Oh, no.
determine which one.
No, it'll be obvious. Yeah. So, do you see that? Do you see what I'm talking about? Those are the patients who you look at and you just hold their hand and just, you know, if they have a fallen tree branch and it's gone through their heart or their lung, you know, there's, so because you have to remember the greatest good for the greatest number of people. And that's where it's hard. I think the triage person would probably be the worst job. The worst job. Because you're the one who has to decide that situation. Okay. Now, in a mass disaster, they also can do what they call reverse triage. And what they do with reverse triage is they divide your situation into zones. Okay? So an example would be a nuclear meltdown at the Duke power plant. Okay? Whatever. So the plant has melted down. So now I've got to get the victims, not only of the plant, but surrounding areas taken care of, okay? So this is more than 100 victims. We've got a mass casualty incident, okay? They're going to divide it up into zones. The hot zone would be the plant, okay? It's contaminated. That zone is considered contaminated. Only people who have the appropriate protective equipment can enter that zone. Okay? Only the people who have the appropriate protective equipment can enter the hot zone. Okay? So the hot zone is the site of the disaster. Okay? Then you've got the warm zone. So if you think about it as a circle, the warm zone is beside the hot zone. It's where you bring people, so for example, the plant, the building itself is the hot zone, okay? Outside the walls are the warm zone, and that's where you would bring your victims out and decontaminate them, okay? One of the things that you have to remember is that decontamination is one of the first things that you as an emergency room nurse have to determine. First, before you touch that patient, you have to determine have they been decontaminated. Does that make sense? Because if you touch them, then you're contaminated as well. So they have to be decontaminated before you care for them. So you've got to determine whether decontamination took place in the zone. So it's beside the hot zone, decontamination takes place, and that's where the initial triage takes place. Okay, so they bring people out of the plant into the warm zone, which is right outside the plant, and they decontaminate them, and then they triage them. How bad are their injuries? Was it a burn that was so bad that we had to give them a black tag, or do they have multiple fractures from a falling piece of equipment or whatever it is? That's where the triage occurs. You still need PPE. It may not be the whole get-up as you would need for inside the plant, but you still, because what are you doing? You're decontaminating them, right? So you still need to be protected, but it may not be the massive amount of equipment that has to go into the hot zone. And then the cold zone is the safe zone. Okay, so if, let's say this building is the plant. Okay, the parking lot would be the warm zone. The cold zone would be
Across the street.
maybe up the street. Okay, up here on whatever the street that is that runs in front of the Core Lab, whatever that is. That area would be the cold zone. So you're away from the outer rim of the plant. Does that make sense? Okay. So So your goal is to get people decontaminated and triaged into the cold zone so they can be treated. That's also where your shelters might be set up. Any survivors, that's where they would be, and that's where transport takes place. So after decontamination occurs, you get your victims to the cold zone, and that's where the EMS is waiting, the fire trucks, whatever, to get them to the facilities. Make sense? So you can think about it as this is the building, that's the warm zone parking lot, the cold zone is where they transport them from. Okay? All right, let's talk about PPE. There are 3 levels, and most of what we think of as PPE is just our basic, we talk about that all the time, contact isolation and all that stuff. PPE is leveled in 3 different levels, A, B, and C. Level A is what you see in the movies where they're hooked up to a oxygen source with the cord, and they're, they look like space aliens. Those are level A. That's the highest level of protection. It is worn by hazmat teams. Those are the kind that have the big hoods on, and it's totally impermeable to vapors and chemicals and everything. Okay, so that's the big alien looking things. Level B provides protection. You're still in a suit, not just a gown. You're still in a suit, but it's not impermeable to vapors. Okay, so you probably are in a suit, but not with a full helmet. You may have like goggles on and stuff like that. You're not totally impermeable to vapors. Okay, and then level 3 is what you consider at the hospital. That's just your regular yellow gown. You might need a TB mask. That's what it's called, a respirator. Those are the TB mask or the blue mask, depending on the situation. You may have to wear shoe covers, stuff like that. But that's level C. That's your basic everyday PPE.
Health employees work would be all of
That would be B. That would be B. Okay. All right. Before we talk about terrorism, we're going to watch this DVD about Katrina. Unfortunately, this is something that we have to worry about now. And again, it could be considered a man-made disaster if it's a terrorist situation, a terrorist strike. This is the actual definition of what terrorism is. The calculated use of violence or the threat of violence it's supposed to be inoculate fear. Intended to coerce or to intimidate governments or societies in the pursuit of goals that are generally political, religious, or ideological. Okay. Our role, what we have to worry about, of course, is the after effects of terrorism. And how do we take care of victims who have been exposed to either chemical, biological, or nuclear weapons? And unfortunately, we live in a day and age now where that is always a possibility. So these are the type of biological warfare and agents. When you are oriented to your hospital as a nurse, they will do a whole presentation on this kind of stuff too. So this is not the last time you will see this. But these are some of the biological warfare and agents that are out there. You probably recognize these names. And again, I remember telling you the other day, what was so interesting is when I was looking back over this stuff, refreshing my memory on this stuff before we started the unit, is that I had found that article that I had saved that said, what if Ebola came to the United States? And it did. So that's something that we don't have, that we have to to worry about now. Most of these biological agents have similar clinical presentations, okay? And those present as gastroenteritis, a pneumonia, or respiratory situation, rash or lesions. But the thing about it is, what are these symptoms? What do they remind you of? They're generic, aren't they? They could be anything. They could be the flu. So it's very, very difficult to pinpoint whether or not someone has been exposed to a biological agent until you start to see advanced signs and symptoms. Now, one thing that you have to think about is how many people are coming from the same area, and that's one of the questions that you always ask people is, have you been in a specific restaurant? Have you been in a specific, where were you before you got sick? After the Ebola scare, one of the admission questions on our nursing admission assessment is, have you been to one of the following countries? Sierra Leone, Liberia, and somewhere else. West Africa, I think it is. One of those countries. There's a whole list of questions that you have to ask on admission to every single patient that comes in. That is something that we never had to worry about before, but now we have to. So finding where they were before they got sick is a very, very important thing. Okay. Of all of these, I'm going to talk to you about anthrax. I am going to give you a handout on Ebola because I want you to, I'll go ahead and give it to you, I want you to at least have, and I think there's a group that's doing an Ebola presentation so they can probably teach you even more. But this is what they handed out at the hospital to the staff about what Ebola looks like and how you prevent transmission. But we're going to talk about anthrax. It is considered still, even with Ebola out there, it is considered the greatest bioterrorism threat. Now, Ebola, the outbreak that we just went through was not a terrorist attack. The outbreak that we went through was an infection that started, I believe, with a young boy. Did anybody hear that? Or am I dreaming that?
Playing with bats or something?
Playing with bats, yeah, and bat guano or whatever.
And the bat bit him or something?
Yeah, and the bat bit him, and that's how it all started. They traced it. I think that's fascinating how they can go all the way back to the source. That it started in a little village when it was a little boy who was playing with bats and got bit, and that's how the whole thing started. So think how far that outreach came. But we're going to talk about anthrax because it is considered the greatest bioterrorism threat. It can be used as a weapon. So there are 3 forms of anthrax. I don't know if you know that or not. There are 3 forms of anthrax. Cutaneous, which of course is the skin, inhaled, and GI anthrax. What happens is that macrophages enter the body and they produce little capsules, and those little capsules in turn produce lethal toxins. Okay, and those toxins are released into the bloodstream and it causes overwhelming sepsis. Does anybody watch NCIS Los Angeles? Am I the only person in here that watches NCIS? That's what DVR is.
Yeah. My daughter watches it, so we'll watch it after.
Okay, well, the NCIS Los Angeles episode the other day was a victim of anthrax. So, the incubation period of anthrax is 1 to 6 days from exposure. So wherever you're exposed, does everybody know that anthrax lives naturally in the soil? Yeah, lives naturally naturally in the soil. But, and I learned this on NCIS Los Angeles the other day, that in the soil, the reason that we don't get infected that way is because it lives in clumps. It's in big clumps, and so they're too big, spores are too big for us to inhale and breathe in, so it doesn't affect us. So the anthrax that we get infected with are all those spores that have been broken apart. I learned that on that show. Okay. So it takes 1 to 6 days for it to incubate, and these are the signs and symptoms that you present with, and they look very much like the flu. Flu-like body aches, headache, a fever, a cough. The problem with anthrax is that they deteriorate rapidly. It is a very quick downward spiral. They deteriorate rapidly, and they go into shock, and then they end up dying. Now, this is a sad statistic. 100% of inhalation anthrax patients will die if not treated. And 95% will die if not treated within 2 days. And how many people with the flu-like symptoms stay home, right? Oh, it's the flu. I don't feel good. And they stay home past those 2 days. That's kind of scary to me, I think. 95% will die if not treated. The treatment is simple, and that's what I think is so interesting about this. Cipro is the treatment. IV Cipro in large doses is the treatment. Okay. Anyone that's exposed to a patient with anthrax should be treated, because you don't know if it was on their clothes or wherever it was that you could have gotten the spores in your body as well. Okay? All right. Now, for disasters, for emergencies, for bioterrorism attacks, there are psychological effects. Okay, and y'all talked about PTSD, right? Inside, y'all know all about it. You should be experts on PTSD, right? Right, experts. There are a lot of things, and we saw this in the Katrina video. We talked about a little bit of that there's a lot of after effects of a disaster, and these are some of them: injury and death, separation from family, which I think is a hard one. You hear stories all the time about they don't know where their family is, or they've been shipped to another state, or they don't know where anybody is. Not having adequate food and water, not having enough utilities, and then you've got all of the individual reactions. These are some of the stress reactions that occur that you might see in people. If I asked you that on a test, you should be able to identify those. Okay? So these are some of the stress reactions that occur for people who are exposed to a disaster or an emergency. Some people deal well with it. Some people, they deal well in an emergency situation. Those of you who are wanting to be emergency room nurses or ICU nurses who can think quickly on their feet, those people tend to do well. But then you've got people who don't deal well with disasters in emergencies, even in their own personal life. They don't deal well with it. And so if you take away their basic human needs, they fall apart. And then you see... So not only are you dealing with patients coming into the hospital that are physically ill or physically hurt, but you're dealing with them mentally hurt as well. And what do you think about this statement one of those nurses made where she was caring for a lady and the woman had just watched her spouse drown in front of her? I mean... Can you imagine how that must have felt and not be able to do anything? So the guilt, the survivor's guilt Did y'all talk about that at some point? Have y'all talked about survivor's guilt? With cancer patients, there's a lot of survivor's guilt. And the same thing with disasters. There's survivor's guilt. You know, they died, I should have died too, or I should have died saving them, or so there's a lot of reactions that occur that need to be taken care of just as well as their physical needs. Because patients, I don't know if y'all talked about this during psych, patients will not heal if their mind and body and spirit are sick as well. They will not get better. So you have to treat the whole person. Okay? These are just some pictures of people in a disaster. Okay. So we need to make sure, this is when we need to make sure that we are better prepared, that we are prepared to handle ourselves in a disaster and an emergency. What I'm going to do now is I'm going to pass out this family emergency plan, and I want everybody to take one, and you can fill out these cards for your own family. These materials are actually on the FEMA website. How many of you have already thought about that? Does anybody have a disaster plan at home? Okay, Angela does. A couple of you do?
I'm in the flyers. Evacuation market.
Do you know exactly?
UNCC.
Yep. Does anybody know what you're going to do? Do y'all have food stockpiled, or your nope? Dog food. I wouldn't go to a shelter if my dogs could go. No.
We all going down with it.
That's exactly right. Everybody's going down together.
We down together.
That's right.
Like on a cruise ship.
Right.
We all.
So, does everybody know? Do you know what you're going to do with your children if you get called to the hospital? You just going to say, "I hope you can take care of yourself"? Yeah. Ben's 10. I hope he can take care of it. He can operate the microwave. Okay.
Hey, they might actually have to eat out of cans.
But it's really, all jokes aside, it is very, very important to have some kind of a plan. Medicines. What are you going to do about your medicines? You know, a lot of people who are emergency prepared keep all their medicines in one spot, so all you have to do is grab them and go. Diabetics, you have to make sure you have your insulins. What else can you think of? What else would be important to know about? Important papers, very important. Birth certificates, social security cards, life insurance policies. Okay, the home insurance, the homeowner's policy, all that needs to be in one place. I have a fireproof box that I keep all that stuff in. So that's something that y'all need to think about if you don't have one. You get those at all copies on a thumb drive. You got to make sure you have the thumb drive. You got to make sure there's a computer that's working to get.
Yeah, you need batteries.
True. Then the fireproof box. The immunizations.
Just a bag of clothes.
A bag of clothes. That is something you need to do. I hope everybody's hearing me. That is something you need to do when you get that license behind your name. In the trunk of your car, you need to have a bag with an extra pair of clothes, an extra toothbrush, toothpaste, blanket, that kind of stuff in your car. Because you may not be able to get home. I'm not wearing scrubs for days on end. Yeah. Okay? Those kind of things need to be kept in the car. Bottles of water. Okay? Flashlights.
Cash.
Cash, yes. Because the bank's going to be, remember, the bank's going to be washed away. Okay? Where is the closest shelter? Do you have any idea where there would be a shelter near you? You know, they only set shelters up at certain places. A lot of times the schools will have a shelter. And will they take your pet? Because I'm like Angela. If they don't take my animal, we're all going down with the ship together. Because I ain't going to a shelter without my dogs. So. Ben, he can go wherever he wants to, but the dogs.
How do you like? Well, you were talking about make sure you got insulin on hand and stuff like that.
And you
Doctors
can't.
will only give you
They
a
will.
certain amount of
Make sure that you can grab it where you know where it is and be able to grab it. So a lot of people keep all their medicines like in a box together. If you know it's getting low, go ahead and get it refilled. That kind of stuff. Have Tylenol on hand. Does anybody watch The Walking Dead?
Yes.
Okay. All right. Now, do you ever wonder what they do for headaches in The Walking Dead? You know that they have headaches
They just keep
walking around forever.
Blood pressure probably sky high.
I think about stuff like that all the time. What would I do in the zombie apocalypse? I would survive a day.
Trying to run from the walkers, smash a key.
Okay. All right. Any questions about terrorism? The Ebola paper that came around is something just for you to have on hand. Okay.